we've not done any formal research in this area, although David may take that on, I'm not sure. I think there are, and I'm really talking about my clinical experience, I think that the consequences of narcolepsy on people's lives, if it's severe, can be really very dramatic, and it's not unusual for people to become quite depressed as a result of their narcolepsy. And I think that one of the reasons why we at Guy's and St Thomas's have set up what we now call the complex sleep clinic is to deal with some of these comorbidities. Are you going to talk about that, David?
I'm going to talk a little bit about that.
Okay, so I don't want to preempt David's talk, but we've now got 2 psychiatrists and 2 psychologists on board to deal with some of these very specific issues, so the comorbidities, the psychological comorbidities that come with narcolepsy. I've seen a few patients, and they're often with swine flu triggered, or swine flu vaccination triggered narcolepsy, who seem to have a more sort of florid psychiatric picture. Okay, I think these are by far the minority, but yes, I mean undoubtedly the incidence of psychiatric issues or psychological comorbidity is higher, and that's been borne out by some now quite old papers actually. Not that I'm aware of. I know that John Schneerson did one about 10, 15 years ago, but I've not. Are you aware of any more recent ones? So just to repeat that for those of you who didn't hear, some population studies have demonstrated an increased risk of depression, anxiety, and social anxiety.
Okay, thank you.
I mean, the answer to that is yes, the short answer. The long answer is, look, all of us are, in between our patients, are looking at Google, hopefully not Wikipedia, for our medical information. There are a number of online resources that help. There are companies like, there's a company called Babylon that's looking at artificial intelligence algorithms to try and make diagnoses over the phone or on the internet. I think what you have to be mindful of is that these algorithms, they tell you what the person reports, but they don't, what the skill in medicine generally is about interpreting the information that somebody tells you in the right context. So I think undoubtedly these technologies are going to help, and they're going to, to be honest, I think the way that they'll help the most is that somebody Googles their symptoms and says, I think I've got narcolepsy. I think that's going to be the biggest technological impact. I think you'll find that there's probably quite a lot of resistance by GPs to allow what they see as their jobs being taken over by technology. I think it's a very separate area of sleep. So I think we now at least understand the basis of the pathophysiological mechanisms that underlie narcolepsy, at least narcolepsy type 1. But it's not thought to be related to the circadian rhythm. And I think that a lot of our understanding is going to come about from understanding the immune regulation of this attack against the hypocretin-producing neurons. So I think it doesn't directly translate, actually, unfortunately. So we know that the psychiatric or the psychological comorbidities are a little bit more common: sleep apnea, periodic limb movement disorder. We don't know why people get periodic limb movement disorder more. We know why people get sleep apnea a little bit more, because that's often associated with weight gain, although in Phil's case he's significantly skinnier than me. I'm very envious. Now, and therefore, by extension, if you've got something that's disrupting your sleep or you are sleep restricted, there are all those issues that we're slowly learning about in terms of the associations between poor sleep and other things like blood pressure, cardiovascular disease, metabolic syndrome. Now, I think we don't really know long term about specific to narcolepsy. That is something that has been mooted. I've not seen any very strong evidence. I know that people are looking at things like increased risk of autoimmune disease. But I think the thing to remember is we know that HLA type, certain HLA types are very strongly associated with autoimmune conditions. I think probably, HLA DQB1 star 0602 seems to be particularly good at generating an immune response against something that mimics the hypocretin-producing cells. And I think these are all areas of study that, with a good database, you guys could answer, actually.
Can you put that in layman's terms?
So what we think happens is that this genetic predisposer, this HLA type that we have, influences how your immune system generates an immune response. And there have been some studies that are, unfortunately one was retracted recently from Manuel Minho's group, that reported that when presented with the H1N1 swine flu or the vaccine, that underlying genetic predisposition that you have is awakened, because that makes it more likely for your immune system to generate antibodies or some immune response against the swine flu or the swine flu vaccine that also recognises the hypocretin-producing neurons. So at the moment we don't know whether that's very, very selective, very specific, or like other HLA types is associated with a range of other autoimmune conditions. I think I read something about the speed of onset that came out of, I think, one of the French groups. So I think there are some distinctions. We're not doing that. I don't think any group in the UK is doing that. I think that one of the things that Paul and I are trying to set up is, in fact, we had a meeting about it yesterday, was a large database which would primarily be restricted to our patients, but actually with the view of opening it up to particular patient groups to allow them to report questionnaires from home, and with a view to collating information on a range of conditions like narcolepsy and Klein-Levin syndrome and that kind of thing. And I think, I alluded to it very early on, which is that I think that a lot of these studies that have been done in the UK in the past have been done on a relatively small scale, were done quite a long time ago, and need redoing. So simply understanding what the current time to diagnosis is needs to be addressed. Understanding the range of the age range of people that are, living with narcolepsy needs to be readdressed. The risk associated with stimulant drugs needs to be readdressed, and we've got something that is about to be published looking at combination therapy, but this is on a relatively small scale, and actually linking in with you guys, I think, would be a really good opportunity to generate some proper, good quality data that will inform us as to how best to manage this condition. Yeah. Look, I think, our understanding is that this is a very specific reaction. And at the moment, we certainly don't think that having other vaccinations or other infections would necessarily increase your risk of anything else happening. This seems to be a very specific association between this HLA type and narcolepsy. So I don't think there's any reason, and I would argue that particularly, the risk of something happening from him contracting measles or, meningitis is significantly greater. So I certainly don't recommend to my narcolepsy patients not to have any vaccinations. No, I agree. It doesn't sound rare to me either. I think for a GP, that when I give my talks, when I talk to GPs, I say, well, look, you probably have at least one person with narcolepsy on your books, and I say, hands up who has got somebody with narcolepsy on their books, and maybe 5% of people will stick their hand up, and I say, well, you need to look harder.
So in a big comprehensive school, that's sort of one person.
I think that's over the whole range, and bear in mind that you over the whole age range, and you need to bear in mind that not everybody gets narcolepsy in childhood. You can get narcolepsy at any age. Okay, so if you think that the average secondary school is 1,500 people, maybe 1,000 people, then maybe 1 in 5 schools might have one person with narcolepsy. One of the difficulties is teasing that out from all the other reasons why a child might be sleepy in class, as I think I've illustrated. Yeah. The question of why it should come on at 15, as I said, narcolepsy can come on at any age. So what you need is a developed immune system. So it doesn't normally come on in infancy, although in some genetic forms it has been described as coming on in infancy. But you need a mature immune system, and you need exposure to, we think, an environmental pathogen, so a virus or a bacterium or something else. And obviously, at the age of 14 or 15, you're perhaps a bit more exposed to a virus at that age. So that may well be why there is this peak. But there is another peak at the age of about 35, 36, and we don't know why that causes it. I think that incidence curve really only tells you about when symptoms are likely to be identified and diagnosed. Okay, it doesn't tell you anything about the progression. And in my experience, progression of narcolepsy beyond a certain stage, and usually the first sort of year or two, doesn't tend to happen unless there's something else going on. So what we often see is that people come in saying, my narcolepsy has been really well controlled for many, many years, and now I'm getting much more sleepy, or my cataplexy has got much worse, and that's often in response to something else disrupting sleep or psychological comorbidities. And actually there is some evidence to suggest that cataplexy actually improves a little bit as people get older. Now, I think some of that is related to the fact that people are better at regulating the triggers for their cataplexy. And I don't know how much of it is biological and how much of it is restriction. Would that be your impression, David, as well? Okay, he's going to talk about that a little bit later. But also what you've got to remember is that as people get older, just because you've got narcolepsy doesn't mean you're not going to get sleep apnea, does not mean you're going to get PLMD, does not mean, and some people with narcolepsy may have insomnia. Usually a worsening is related to something else coming in and complicating narcolepsy rather than the underlying narcolepsy getting worse. I think the short answer to your question is no. As you know, there are lots of efforts at the moment in terms of trying to develop new treatments for hypersomnias in general. So you've already heard today about the Flamel drug that is being trialled at the moment, which is a slow-release preparation of sodium oxybate. There is another formulation by Jazz, which is a low-salt version. There is now pitolisant, which we have very limited experience of in the UK, which is a new-in-class drug that acts on an entirely different system that is said to be at least as effective as or roughly as effective as modafinil, but perhaps with a slightly different side effect profile. In terms of long-term treatments, in terms of long-term consequences, I think sodium oxybate has not been around for long enough to really know. We've recently published a paper describing our own experience with sodium oxybate, because what we, in the UK, we use sodium oxybate in a very different way to, for example, in the States. In the States, they use it as a first-line treatment for people with mild, moderate, severe narcolepsy. In the UK, where you can get it, so we're lucky in our centre in that if you meet certain criteria, you can get sodium oxybate, but even then, you're going to be at the more extreme end of the range. And so we've published recently a paper describing what has happened to our first 90 patients on sodium oxybate. And, of those, about 60% stay on sodium oxybate because they don't have any side effects. In terms of serious side effects, we've had 3 people who have developed serious neuropsychiatric side effects, all of which have reversed when the sodium oxybate has been stopped relatively quickly. So, but we don't have data about the long-term consequences of sodium oxybate. We think that, in some people who start sodium oxybate, they lose significant amounts of weight. I don't know if anybody has had that experience when they've started sodium oxybate. Yeah. So clearly that has health benefits associated with it. And then in terms of stimulant drugs, most of the work regarding safety in stimulant drugs has come out of very large studies in the States where they've looked at the use of dexamphetamine and methylphenidate in patients with ADHD. And they've got 2 large studies looking at kids and adults between the ages of 18 and 64 that have got something like 1.3 million years of exposure, and have found that if you don't have any underlying cardiac issues, then there's no increase in risk. Now, that we're still not entirely clear on that, but certainly that at least suggests that the signal is not very strong, that the association is not very strong. I think you're absolutely right. I think, however, we need to focus on everybody, and I think that it needs to be part of the medical school curriculum, and I think it is starting to be. It needs to be on the GP curriculum. It's recently got onto the neurology curriculum, believe it or not, because when I trained, I don't think that there was any stipulation upon learning a little bit about sleep, whereas I think now it is part of regular training days for neurology registrars. I'm getting an increasing number of registrars who say, can I come in and sit on a few of your clinics, because they need to get that ticked off their training. So I think things are moving, but I think that, psychiatry is certainly much more active in sleep now, and are really understanding the importance of sleep in managing psychiatric disorders and the interaction between sleep and psychiatric disorders. And so I think things are changing, but I think, I absolutely agree that focusing on the GPs is a very good sort of efficient way of doing it. But I think actually we as a medical profession, rather than you as a group, need to be much more proactive in pushing it even earlier at the level of medical school.